Welcome back to Deep Dive Ortho. Now, typically when we sit down, we're dissecting, the latest registry data on revision arthroplasty or getting lost in tribology. We love the hardware.
We do.
But today, we're stripping all of that away. We're looking at the one instrument in theater that probably determines the patient experience and the outcome more than any robot or scalpel.
And that is the surgeon's own psyche.
Exactly.
It is a bit of a departure from pure biomechanics, isn't it? But, well, it's arguably the most critical piece of equipment we actually have.
I completely agree. We're diving into your recent work, The View from Under the Drapes, which I have to say is a frankly jarring read for anyone who spent their life on our side of the healthcare divide.
Yeah.
You start with this very specific, almost visceral image. The waiting room, 3.17 p.m.
Yes. It has a very particular frequency of silence.
It's not a peaceful silence, though, is it?
Not at all, no. I call it the silence of suspended agency. Think about our lives as surgeons. We move through the hospital, well, like apex predators. We have the swipe cards, the authority. We are the protagonists.
You walk into a room and the whole dynamic shifts.
It shifts around you. But when you're the one sitting in that plastic chair, in a gown that doesn't quite close at the back, that entire dynamic just collapses. You're no longer holding the space. You're the one needing it.
That's the mirror moment you describe. It must be a colossal psychological gear shift. You spend decades wearing your role like armor, the clinician, the professor, the fixer of broken things, and then suddenly your name is at the top of the report.
It changes everything. I remember lying on a trolley, just staring at these ceiling tiles I'd walked under 1,000 times but never actually seen, and I was waiting for major surgery.
Yeah.
In that moment, I looked at the sterile drapes.
Right.
From day one, we're taught drapes protect the wound from germs. The sterile field, it's sacred. But lying there, I realized they serve a dual purpose. They protect the wound, yes, but they also protect the surgeon from feeling. They separate the pathology from the person.
That's almost a perfect description of what Foucault called the medical gaze, isn't it? This idea that to practice medicine, you almost have to separate the body from the identity.
Precisely. Foucault argued that the medical gaze looks at the fracture, not through the person. And it's a necessary detachment. You can't fall apart emotionally every time you see a shattered tibia. If you did, you couldn't operate.
Of course not.
But my argument is that we've let that detachment metastasize. We've prioritized the hardware of orthopedics, the implants, the robotics, and we've almost completely neglected the software.
By software, you mean the relational intelligence.
Exactly that. The software is what dictates how a patient actually experiences their own healing. We're seeing this quiet normalization of, well, dehumanized care. It's driven by throughput, by digitization, the sheer volume. We treat the image, not the patient.
So the mission of this deep dive is what, then? To operationalize that soul.
It's to argue that we need to operationalize the soul of surgery. We need a framework to counter burnout, to counter this erosion of empathy, not just because it's nice, but because the data shows it actually changes clinical outcomes.
Okay, so before we get to the solution, your 5 C's, we need to properly diagnose the problem. And I have to say, you use one of the most accurate, if slightly strange, metaphors for orthopedics I've ever heard.
The coconut and the caramel.
The coconut and the caramel.
It does stick with you, doesn't it? It sounds a bit absurd, but it's clinically precise. Orthopedics is a discipline of binaries. A fracture is either united or non-united. A joint is stable or unstable. A nerve works or it doesn't. This is coconut mode. Hard, distinct, binary.
And in a trauma bay, you absolutely need the coconut.
You do. You absolutely do. With a pelvic ring disruption and instability, you don't want a surgeon contemplating the poetry of existence. You want someone who can find the signal and the noise and make rapid binary decisions. It reduces cognitive load.
But the danger, as I see it from your work, is when we live in that mode exclusively, when we're inside the coconut 24/7.
That's where the pathology lies. Because then we start to see anything that isn't hard data, a patient's fear, their story, as noise. We try to filter it out. There's significant work by Hojat and his colleagues on this erosion of empathy. They found that empathy scores in medical students plummet during their clinical years.
So it's not that we select for people without empathy, it's that the training beats it out of them.
Or, rather, the system forces them to armor up. They suppress it because they're overwhelmed. But this binary thinking, it has real casualties. I talk about a case, a patient with ovarian torsion. That's a perfect example of the coconut failing.
Walk us through that, because on paper, the coconut approach seemed to work at first.
Initially, yes. The patient arrived in A&E in agony, 11 out of 10 pain, but her biomarkers were normal, vitals were stable. The binary system, the coconut looked at the data, saw normal results, and concluded No pathology. She was discharged.
With a diagnosis of stress or anxiety? The ultimate dismissal.
It's all in your head. Exactly. Hours later, she returned in shock. She had an ovarian torsion, a surgical emergency. The system failed her because it prioritized the binary data, and it completely ignored the narrative. It ignored the caramel.
The caramel mode being, what? The sticky, messy, nuanced reality of human suffering.
Precisely. Caramel is complex. It doesn't fit in a tick box. And as surgeons, we are often uncomfortable with the caramel because, well, it takes time. It requires us to sit with uncertainty. But pain wants to be understood just as much as it wants to be fixed.
So we have the technician, the coconut, and the healer, the caramel. And the goal isn't to choose one, but to reconcile them.
Yes.
And this brings us to the philosophy of the wounded healer. You're drawing on Carl Jung here.
Jung argued that a doctor is effective only when he is affected. Only the wounded physician heals. Now, for a lot of us in orthopedics, that sounds completely counterintuitive. We're trained to be invincible. For years, I thought my value was entirely my control, controlling the airway, the tourniquet time, the reduction.
But your own illness destroyed that illusion.
Completely. And that destruction of ego, it leads to what I call the control dividend. This is a concept I think anyone listening can apply. It's really about energy economics.
How does that work?
Just think about how much energy we spend trying to dominate things we can't control, biology, statistical outcomes, the chaos in the NHS. When you stop spending your energy there, you liberate this massive dividend of energy.
Which you can then reinvest.
You can invest it in what you can control.
Yeah.
Your response, your attention, your connection with the patient. It shifts surgery from being purely transactional, I fix your bone, to being transformational.
Okay, so that's the philosophy. But we did promise the listener a toolkit. You've proposed the 5 C's of the modern surgeon. This is how we actually operationalize that caramel mode. The first C is consciousness.
Right. Consciousness here is defined as the manual override. We have to look at how our brains work. We're athletes of the fast brain, what Daniel Kahneman calls System 1. We operate on pattern recognition.
Which is brilliant for reading an X-ray in a split second.
It is, yeah. But the shadow side is drift. We suffer from what's called inattentional blindness. We see the fracture, but we miss the terror in the room. We miss the person. So I suggest a very specific micro-habit, the door handle reset.
I can already hear the skeptics. I've got a clinic of 40 patients. I don't have time for a meditation session at every door.
It isn't a seance. It takes 3 seconds. Before your hand turns the handle, you just pause. You ask yourself 2 questions. Who is this person? And who am I being right now? It's a 2-beat pause to drop your shoulders, to switch your gaze. It breaks the drift. It rehumanizes the room before you even enter.
That seems quite manageable. And it leads directly into the second C, compassion. Now, you're very clear on this. This is biology, not sentiment.
This is pure neurobiology.
Yeah.
It's based on polyvagal theory from Stephen Porges. A patient's nervous system is constantly, unconsciously scanning the environment for cues of safety or danger. It's called neuroception.
So if a surgeon rushes in, flat expression, hurried tone, looking at their iPad,
The patient's brain reads threat. It triggers a fight or flight response. This actually increases their pain perception and anxiety. Compassion, in this model, is a clinical intervention. It is the regulation of one's own nervous system to help stabilize another's.
is there hard evidence that this actually impacts outcomes? Or is this just about patient satisfaction scores?
It impacts both.
Yeah.
But the perception gap is staggering. Tung and his colleagues published a study showing that 75% of orthopedic surgeons felt they communicated satisfactorily. Do you know how many of their patients agreed?
I'm going to guess it wasn't 75%.
21%. It's a massive disconnect. And other studies show that patient satisfaction correlates more with empathy than with the actual radiographic reduction of their fracture.
So you can have a perfect X-ray, but if the patient felt unheard, the functional outcome is often poor.
They don't do their rehab. They don't trust the process.
That 75 versus 21% gap really highlights the need for the third C, connection. You talk about design proximity.
This is all about countering what Martin Buber called the I-it relationship, where the patient is just an object. Connection requires tactics. It means sitting down instead of standing. That immediately levels the hierarchy. It means eye contact before the screen. But the most powerful tool is what I call the haptic bridge.
I love that term, the haptic bridge.
We are losing the habit of touch. We rush to the digital image. We treat the MRI. The haptic bridge is simply the act of palpating the painful limb before you look at the X-ray, even if you know what it's going to show.
And why does that order matter so much?
Because touching the patient first signals, I confirm your pain exists in your body, not just in my computer. To touch is to testify. It validates their suffering. If you look at the screen first, you're telling them the truth lies in the data, not in their experience.
But let me play devil's advocate. The overworked registrar trying to get through the list thinks, I just don't have time for this.
And that is the efficiency myth. We think being curt saves time. But the evidence shows if you simply listen for 2 minutes without interrupting, the patient will disclose 80% of the necessary clinical data. If you interrupt, which we do on average within 18 seconds, the consultation actually takes longer.
Because you have to go back and fish for information.
Exactly. Connection actually buys you time.
That's a powerful reframing. Let's move to number 4, curiosity. This feels particularly relevant now with the rise of AI in medicine.
It's critical. AI is the ultimate coconut. It is faster, sharper, more binary than any human will ever be. It will outperform us in pattern recognition. If our only value is being a technician, we lose.
So where do we fit in?
AI hits a ceiling. It can predict a non-union, but it cannot witness suffering. It cannot fear. Curiosity is the refusal to accept the algorithm's label. When a patient has nonspecific symptoms, the algorithm says discharge. Curiosity asks why. It looks for the story under the story. The caramel mode is the only territory AI cannot conquer.
Which brings us to the final and perhaps the hardest C, courage.
This is the one that requires the most internal work. We're trained to project this air of invulnerability. The God complex is a cliche for a reason. But true authority comes from authenticity. I lean on Brené Brown here, clear as kind.
And what does that value-anchored courage look like when you're talking to a scared patient who wants a guarantee you can't give?
It means having the guts to say, I don't know, or I cannot promise a cure, but what I can promise is you will not walk this path alone. It's placing the patient's need for truth above the surgeon's need for ego.
So if we integrate all 5 C's, consciousness, compassion, connection, curiosity, and courage, the end goal is what you call coherence.
Coherence is the antidote to burnout. We survive by fracturing ourselves. The hard technician at work, the soft human at home. That fragmentation causes moral injury.
And moral injury is different from burnout.
Very different. Burnout is exhaustion. Moral injury is a violation of your conscience. It's when you know the patient needs caramel care time, empathy, but the system forces coconut efficiency. That gap tears you apart.
Yeah.
Coherence is the refusal to compartmentalize. It's aligning the hands with the heart.
Which you then link to the concept of anti-fragility.
Yes, from Nassim Taleb. If you're fragile, like glass, you break under stress. If you're resilient, you bounce back to where you were. But bone is anti-fragile. When you load bone, it doesn't just bounce back, it remodels. It gets stronger.
A coconut surgeon is fragile.
If the shell cracks, they shatter. A coherent surgeon is anti-fragile. By actually metabolizing the emotional load, by feeling the caramel, they grow in wisdom. They get better because of the stress, not in spite of it.
So how do we actually implement this? How do we teach it to a registrar who just wants to learn how to nail a femur?
You have to grade it. If you don't measure it, it doesn't improve. I propose a narrative debrief. In trauma meetings, we put up the X-ray. We talk classification, approach, implants. I suggest adding one more question. What is this patient's greatest fear regarding their recovery?
That would stop the room, wouldn't it?
It does. And if the trainee can't answer, it means the history is incomplete. It forces the caramel into the coconut environment. We should also grade the physical interactions. Treat design proximity as a procedural skill. Did they sit down? Did they pause? We need to grade these things with the same rigor we apply to AO principles.
As we wrap up, this whole discussion makes me think of the legacy of Sir Robert Jones, the father of modern orthopedics.
It's the perfect closing image. He was legendary for his speed and his technical skill, but history remembers him for his gentleness. He built these architectures of care during World War I. He understood that cutting into a human body is, well, it's a transgression.
That's a heavy word, transgression.
But it's true, isn't it? It's an act of controlled violence. We slice skin, we saw bone. It's only justified by a moral contract. Strangers allow us to induce unconsciousness and rebuild their very framework. That trust is terrifyingly high.
As it should be.
It should make our hands tremble just enough to keep us humble. The view from under the drapes is lonely. We can't always cure. We can't fix every problem. But we can refuse to let the patient walk through that valley of fear alone.
A powerful reminder to reclaim the artisan soul of the profession, not just for the patient, but for the surgeon's survival, too.
Absolutely. It's the only way to last in this job without losing yourself.
If this conversation resonated with your practice, Or if you think a colleague needs to hear about the coconut and the caramel, please take a moment to rate and share Deep Dive Ortho. It helps us keep these conversations going. Thanks for listening.